We too have wondered why the results have been so difficult to interpret and translate. And one of the reasons, and we won't have time to go into, is the manner in which the data was presented in a very confusing statistical method, and the other was patient selection. So under the Freedom of Information Act, we were able to get the data set as required by the government. It was the only way we could get the raw data to analyze the data in perhaps a somewhat a different fashion, and to look at the original hypothesis of the net to see if patients who met that hypothesis, what type of results they had. Also, the net data was not possible to compare with any other data because it did not give you the mean improvement at 6 months, 1 year, 2 years in exercise capacity, FEV1. It was a totally different type, a fairly arcane statistical analysis. There was a net hypothesis. It was in the minutes of the committee meeting before the trial began. It was based, as Dr. Wood said, really on an initial assessment of about 700 cases that they looked into that had been done before the net. And on the basis of that review, they said, we will predict that the patients who benefit from volume reduction are emphysema patients whose distribution is heterogeneous, that is, one part of the lung, usually the upper lobe, worse than the other parts, involving primarily the upper lung zones. That was never tested, and this data was never available before. Because when they actually did the trial, and this comes from the trial paper, they, in spite of the hypothesis, decided to widen the net and include all patients who might benefit, not just those who had in the past been seen to benefit, but many other patients who did not meet the hypothesis. So we got the net data. Fortunately, the net trial was very precise in defining how you define heterogeneous distribution, how do you define upper lobe predominant. So we merely took the net data, applied their criteria, and we found that of the 571 patients who actually underwent bilateral lung volume reduction surgery, there were 261 patients who met, according to net standards, the net hypothesis. 257 patients met the net criteria for homogeneous disease, and 53 met heterogeneous lower lobe predominant, and this includes all of the patients who had LVRS. So I'm going to refer to this as the target group. This is not post hoc analysis. This is using the hypothesis to see, was the hypothesis correct? The 90-day mortality, as Dr. Wood pointed out in this group, was 5%. In the surgical arm, 1.6% in the medical arm. This is the survival curve. And they had complete survival data out to 5 years. So there is a survival benefit when you limit your experience to those patients who met the hypothesis. The improvement in the FEV1 in the surgical group, there were 261 in the surgical group who met the hypothesis for the target group, and 250 in the medical group. And this is the result. Very significant difference, and clinically significant, not just statistically significant. The reduction in residual volume out to 3 years, because there's a very limited amount of data after 2 to 3 years in the NET trial. Again, the medical group, the surgical group, no question. Having analyzed the data by the mean improvement in FEV1, RV, etc., we are now able to compare it for the first time with our series of 250 consecutive, not randomized, but consecutive cases. And also you can now compare it with other series. And Anna Marie Ciccone, as I said, presented our first consecutive 250 patients, bilateral, upper lobe volume reduction surgery, using criteria similar to these. These were the only ones we did generally were heterogeneous distribution, and almost all of them were upper lobe predominant. And it was phenomenal. I thought when these were brought to me that there was a mistake in this data, and you'll see why. Both series, bilateral LVRS. The Ciccone, the Washington University series, 4%, 5% mortality. The same thing. The survival curve of the two LVRS groups, identical. the improvement in FEV1 over baseline, starting off at about 25, 26%, and going up and gradually falling off over 5 years. And this is the percent predicted, the mean percent predicted, superimposable. The reduction in residual volume, that's good, down is good. Exactly the same, 31% in both series at 6 months, and some deterioration, but still good preservation over time. We then looked at this business of baseline exercise capacity, and one of the reasons I think, Doug, that pulmonologists don't refer is they don't want to do cardiopulmonary exercising testing to find out who's low exercise, and as you pointed out, that didn't hold up. Take the target group of patients, the 261, use the NET criteria for high or low baseline exercise capacity, and compare the two. On the left is the low baseline exercise capacity, surgery versus medicine, and the high baseline exercise capacity, both of great value. Take the residual volume reduction, the low baseline exercise capacity of the target group, and the high baseline exercise capacity. Equally effective. Take the low baseline exercise capacity and look at the quality of life. Surgery versus medicine, surgery versus medicine. You don't have to do more than glance at those slides to see that it's of significant benefit equally to both groups. Take the increased workload in watts, the mean improvement in the low baseline exercise capacity and the high baseline exercise capacity. If anything, it's even better than the high baseline exercise capacity. Again, this is the target group, heterogeneous upper lobe predominant. So we conclude that patients most likely to benefit have heterogeneous distributed emphysema involving the upper lobes predominantly. They got it right. The hypothesis of the NET trial, which they've never published the results of before, got it absolutely correct. The problem was that more than half of the patients didn't meet the hypothesis, and so it diluted out the data. When appropriate patients are compared with similarly selected group of patients in at least our series, and that's true of all the series, the results are the same. And for NET patients with homogeneous disease, I don't have time to show you that, there was a 10% mortality in 90 days instead of 5%, and there was a very limited benefit. I'm sure we'll discuss that later in the panel. And it doesn't matter whether you have high or low baseline exercise capacity. I don't have time to show you, maybe in the discussion. The survival curves, by the way, are exactly the same. The survival curves for the surgery group, high and low baseline exercise capacity, superimposable. The survival curve for the medical group, high and low baseline exercise capacity, superimposable, with the surgical group in both being, of course, better. So if you look at the right group of patients, like everything else in surgery, you get the right results. And I believe part of the problem with the NET trial was that initial exclusion, and then they changed the rules and included some high-risk patients, found that they had a very high mortality, then they excluded them again, and I think it led to a lot of confusion, and I believe the statistical methods by which it was presented make it almost impossible to compare with other series, and I think have led to the misunderstandings which have been promulgated by the NET trial. Thank you very much.
Thank you, Joel.